Hello, everyone. Welcome to our webinar for the California Child and Adolescent Mental Health Access Portal, CalMAP. We now have a new name, but we're still the same group and same service. If we can advance the slide, please call us at 800-253-2103 or request a consult online at calmap.org. And here you can use and scan the QR code if you want to get access to to our website. Our operating hours are Monday through Friday, 8:30 to 4:30 p.m. Next slide, please. We provide real-time consultation that includes clinical and personalized guidance on how to apply what's taught in our webinars to your own patient's care. So give us a call if you're interested in any of the content that we will be covering and talk about today. Here's our disclosures of the funding that we received for CalMAP. Next slide, please. Oh, maybe advance the next slide and see if there's another slide that is relevant to the CalMAP new school safe space toolkit. I think Rita mentioned that. Oh,
I'll
Rita,
stop share so Rita can share that slide. I don't have that slide.
thank you. Yeah, Rita, if you're able to share the safe space toolkit, I can also mention that part, which is new to our CalMAP offering. And just wanted to share a little bit more about the 2024-2025 new curriculum. We now provide a core curriculum, live webinars, and as well as on-demand webinars. So there are also new different types of project echoes. Rita will provide a link to our new education offerings. So if you click on if you use the QR code, you can get to our new curriculum for 2024-2025 academic years. And our highlight of the new content is we have on-demand monthly webinar series. We also have different types of project echoes. We have PCP echoes, school echoes, and therapeutic skills echoes that welcome everyone, all types of providers to join. If you viewed the webinars, the on-demand webinars, once you finish watching it, you can answer the questions afterwards. And then once you get a passing score of 66% or higher, then you will earn 1 hour CME and 1 hour American Board of Pediatric MOC Part 2 credit for each of the webinars you completed. At the end of today's webinar, make sure that you either click the link at the end of the webinar, we'll show the slide with the QR code, and we'll also provide the link in the chat so you can claim CME credits today if you stay until the end of today's talk. For our session today, the topic is racism, healing racism-based trauma. I'm Eileen Wayne. I'm one of the child psychiatrists at CalMAP. I staff 1 day a week. I also help organize CME and educational activities along with our wonderful CME team. Before we begin to introduce our speaker today, I have a few housekeeping items. First, our session today is being recorded. It will be posted on our CalMAP website for viewing a few days after today's session. Another thing is if you have any questions during the presentation today for our speaker, please use the Q&A feature in the webinar so we can track them and also present them to the speaker for a live Q&A at the end of the talk today. For the sake of time, I'm going to introduce our speaker today, Miss Saun-Toy Trotter. She was born in New York and raised in the Southeast. The Bay Area has been her home for over 30 years. She's a healer and psychotherapist with over 20 years of experience providing trauma-informed and culturally responsive behavioral health care to adolescents and families. She has experience in school health centers, residential treatment facilities, inpatient, and psychiatric units. And her practice is rooted in youth development principles. As a clinical director of school-age youth and adolescent programs at UCSF Manual Children's Hospital, Oakland, she has expanded school-based services to include health education and youth advisory boards. Ms. Trotter is a contributing author to School Social Work, Engaging School Justice and Racial Equity from Practitioners' Perspective. She has provided training and consultation for many child-serving organizations. She is committed to evidence-based and culturally rooted practices that foster individual and collective health, well-being, and liberation. She loves working in schools, and she's a mother, aunt, daughter, and spouse. Um, it's a pleasure to have our speaker, Ms. Trotter. Today, I'll turn the table over to her.
Thank you, Dr. Wing, for that introduction. And I'm really glad to be with all of you today and talking about this topic of undoing the impact of racism and healing race-based trauma. Our learning objectives for today are to have you leave with a common definition, a shared definition of racism, race-based stress and trauma, to identify strategies that address race-based trauma and promote healing, and also identify strategies that you can share with parents and caregivers to address the impact of racism on children and adolescents, as well as identifying resources for children and adolescents to address the impact of racism. I wanted to start with this image of Sankofa. Sankofa is a word that comes from the Saun-Toy language from Ghana. And it's an image of a bird that is flying forward, but that is also turning back, right? The word Sankofa means to turn back, to go back and get. And so it's so important in our work as providers, as healers, as physicians and therapists and social workers and health educators, for all of us to, as we're moving forward, to recognize and reckon with our past, to identify and acknowledge past pain points, as well as the resources, the resilience, the cultural gifts as we meet people in and meet communities inside of their care. Also, as any time that we're talking about trauma, I invite each of us to remember the things and the people and the practices that help ground and recenter us. We may notice our own activation during this talk or even just hearing the title. And so I invite you to come back to your breath always, to bring an image to mind that is healing of a safe place or a calm place, to remember the people and the communities that support you, and also to have the 988 crisis lifeline that is available for community members, for clients, for providers, for educators, for all of us. I also want to draw your attention to this image of a provider and a young person and a teen, and think about the space in between them. Each of them brings their own culture, their own class identity, their own nationality. Each of them has their own race and ethnicity, their own gender orientation, sexual orientation, and abilities. And all of that is here in the space between. Each moment we meet with a person, a patient, a client is an opportunity to heal, is an opportunity to provide affirming care, an opportunity to meet them in their dignity, and to name and acknowledge all of who they are as they're coming into treatment, as well as to acknowledge the messaging that they get about their identities, about who they are, about their culture and race, about their class, about their gender and gender identity. And we start by locating ourselves. The reason I included in my introduction that I, was born in New York and Southern raised and lived in the Bay Area, because that is part of the identities that I brought. My ancestors were enslaved Africans and people who were brought over to this country from China to work on the railroads, right? And holding all of those cultures and all of who I am is what I bring into our work. And so part of what we do as we gather as mental health clinicians, and I invite you to think about in your clinics, is that we start by locating ourselves, our own ethnicity, culture, gender, sexual orientation, and also to reflect on what parts of your cultural identity do you draw upon as a provider. What are those things that help and support you? It may be the ways that you may be rooted in community. It may be your culture's connection to spirituality. What do you draw upon? It may be your interest in data and researching. But what parts of your cultural identity do you bring into your work as a provider? And probably all of them, but what parts do you intentionally draw upon? I also invite you, as you're listening, as you're here, bringing your presence and attention today, to notice in your body, where are you comfortable and what is your growing edge around addressing racial trauma? I bring these words from Dr. Jennifer Mullen and her book around decolonizing therapy, and this invitation that we seek to dismantle all forms of oppression and that we recognize our freedom, our rights, and that our liberation must be collective and therefore include the most vulnerable among us. And part of that is maybe we talk about colorism and bringing together what you're doing today is talking about and naming and acknowledging race-based trauma, including anti-Black racism. And this is just in part of her introduction to her book on decolonizing therapy. So we start with grounding us all in an invitation, in a definition of trauma. And trauma is an event or threat or is an event that is a threat or perceived to be a threat or an assault. And so take a moment and hold that. Something that is an event or events, right? That is perceived to be a threat or an assault to a person or peoples. And that experience overwhelms our body's natural ability to cope, leads to disintegration, and can leave one in a state of flight, so avoidance, disconnection, running away, or flight or fight, or freeze, or fawn. And this event can be experienced directly or indirectly. And there are many different types of trauma. And today we're focusing on the trauma that is complex, that is interpersonal, that is historical, that gets passed down through generations, and also is insidious. When we think about racism and white supremacy, it's in the smog that we move through, right? It is in our institutions, it is in our media, it is in our books, right? It is not always direct, but it is kind of baked into our society. I want to lift up the work of Trauma Transformed and their work both in San Francisco Department of Public Health and throughout some of the Bay Area counties around creating a trauma-informed system that really holds that trauma is pervasive, it's a long-lasting public health issue, and it impacts all of us, not only the people that we are working with and partnering with for their healing, but our workforce, our systems. And our service delivery systems can inadvertently reinforce oppressions and create harm. And when our systems are acting from a reactive or traumatized place, it can prevent us from effectively working with each other and the people that we serve. And so the time that you're dedicating today and this work is really helping us shift from being trauma organized, from being reactive, from inadvertently reacting from a place of baked in oppression to moving towards creating a healing system. I want to lift up also the work of RISE, who we're all familiar with the ACEs study, which was a study that was done, a landmark study that was done in the 90s through Kaiser and the CDC, that really named and helped us as a field recognize the impact of adverse childhood experiences on our health conditions, on the ways that we cope, on disease and dis-ease, and even on our life expectancy level. And what RISE and others did was said we can't just hold kind of that individual experiences that happen inside of a family, but we need to hold that family, that child, those caregivers in context of what is their social location, where are they living, how does their historical factors impact, including historical traumas like racism and generational embodiments that gets passed down, and also the context of white supremacy and oppression that family, that children, that babies are growing up in. That informs the interpersonal trauma and violence that might happen inside of families, and then the stress load and then the way that cope. What we know that is that ACEs is not destiny, right? And there's ways, as long as we're recognizing and applying direct coping strategies and collective strategies, that there is healing that is possible. And we'll come back to that. Dr. Kamara Jones defines racism as a system of structuring opportunity and assigning value based on the social interpretation of how one looks, which is what we call race. We know that race is not a biological fact, but it is baked into our society and how we treat each other, and unfairly disadvantages some individuals, including Black, Indigenous, people of colors, and communities, and unfairly advantages white individuals and communities, right? And we see this throughout our education institutions, our banking and lending institutions and financial institutions. We see this through our law, our medical institutions. And in that, it saps the strength of our whole society. So racism does not only impact people of color, but it impacts all of us through not really accessing and developing and creating resources for all of our society. And so in that, it saps the strength of our society, and that it is structural, systemic, institutional, interpersonal, and internalized. And I invite, if you have not been exposed to Dr. Jones' work, please go and look up her work right now or after this talk. I also want to lift up Dr. Joy DeGruy, who has been talking about post-traumatic and writing about and teaching and educating about post-traumatic slave syndrome, and the way that the impact of chattel slavery still affects families, the way that mothers and fathers and grandmothers and aunties interact with children, and a child's experience today, and how that racism, anti-Black racism, is really steeped into many institutions. And so appreciate Dr. Joy's DeGruy's work here and really pioneering this work for all of us. And tying this back into a system of trauma-informed care, if we think about health outcomes for, the high rates of heart disease and diabetes for Black communities, if we think about the high rates of alcoholism and suicide for Indigenous communities, we can go on and on. And what I want us to look at is not there's nothing wrong with those communities, but we want to pay attention to what is the context, what has happened, that will help us really see the incredible resilience, the resources, the cultures, the things that cultures are doing to promote healing and well-being in spite of what has happened to communities. So taking a moment to define race-based traumatic stress, and really appreciating the work of Dr. Comas Diaz and others on naming racial trauma. And you'll see that I am going back and forth between race-based traumatic stress or racial trauma and racism-based traumatic stress. And the literature right now in our literature is race-based trauma, and that's what you'll find. But holding that, it is not traumatic to be of a particular race, of a particular culture. The trauma comes from the dangerous events, the real and perceived experiences of racial discrimination, which may include threats of harm and injury, may include humiliation and shaming events, may include loss of housing, it may include witnessing racial discrimination towards other people of color. And it is similar to post-traumatic stress disorder, but it's unique in that it involves ongoing individual and collective injuries, and that these injuries are exist before a human is born and after they die, right? That exposure to and re-exposure to racism-based stress and acute events and trauma. And so a lot of times we think about, oh, is it the thing that happens interpersonally between people, but it's also the lack of housing, the inability to access culture responsive healthcare, the lack of representation and education, right? And this is something that we can do something about as medical and healthcare providers. Many of the symptoms of race-based trauma are similar to post-traumatic stress disorder, including hypoarousal, difficulty sleeping, nightmares, a sense of avoidance, hypervigilance and looking out for threat or danger, or this high sensitivity to threat and danger, having a startle response, difficulty sleeping, and that if untreated and unaddressed can result in other comorbid disorders, including major depression, anxiety, substance misuse, including psychoses. Right? And so it's so important as medical providers and healthcare providers that we are integrating the identifying and ways to treat and address race-based trauma. And so I'm going to share a few screening and assessment tools and invite each of us to familiarize ourselves with these tools, but also to think about those questions. So if I'm not going to do a whole tool inside of a patient visit, perhaps I can familiarize myself with some of the questions so I can start the conversation, or at least open the door, and let the person that I'm partnering with for their health and well-being know that I am acknowledging that this is a stressor that they may experience, and really listen to their answers and what their experience is without making assumptions. One tool, the SMART tool, that was created, the self-assessment for modification of anti-racism tool it was created for organizations engaging in self-directed anti-racism work. And this is a tool that we've used in our school-based health clinics, and engaged our HR department, engaged our equity and inclusion department, to identify like what ways where are we doing well in this work, and what is the work that we still have to do. One example of a question in the SMART tool is strengthening our partnerships and alliance with community members, and really that we are listening to and including representation of people with lived experience. One way that the school-based health clinics that I'm a part of in our FQHC is that we have a consumer advisory board, we have a youth wellness advisory board, and a youth design team, and looking at ways to really integrate in our policy and our practices, ways of integrating people with lived experience into decision-making roles and processes. And so invite folks this is a great tool to be able to use to assess your clinic or your organization. And you can start small. You can start with just one clinic or one practice, and really think about then, maybe we can elevate this to our whole organization. The following are some tools that can be used more individually with patients and clients, including the racial trauma scale. And this is a scale that was created for people to think about the times that they've experienced or have seen or heard about. Again, coming back to the definition of trauma, it's not only directly experienced, but also maybe what we've seen on TV, what we've heard through the media, what we've heard our grandmothers or our parents say, that as a result of racial discrimination. And so some of these questions include difficulty connecting with other people in terms of what your symptomology may be, feeling that society is unfair, reacting angrily, avoiding certain situations. Again, here's the avoidance, or speaking to certain people, feeling less than, the impact on self-esteem and on how their own internal view of themselves, finding it difficult to cope, worrying about one's safety. Another screening tool is the Unrest, which is from the University of Connecticut, which is a screening and assessment tool. And I just want to share the introduction to the interview, and you may be partnering with your behavioral health providers in terms of using this tool. And again, part of healing is like, if we don't ask, we don't know, which is why we screen and ask questions. And we want to screen where we have once we know, that we're also giving people tools. And so this is acknowledging that sometimes people have very bad experiences that cause feeling of stress or even trauma. And sometimes people have difficult experiences over a lifetime that are managed individually, but collectively, again, thinking about that compound stress and stress load, that it can lead to feelings of stress and trauma. And so we're telling our patients and clients that we want to talk about some of their experiences as it relates to race and ethnicity. And if we're unclear about their race and ethnicity, we ask them how they would describe it for themselves. And the last tool I'll introduce to you is the race-based traumatic stress symptom scale. which again is used for assessing the presence of stress and traumatic stress related to racial discrimination and experiences. And this scale looks at anger, depression, intrusion, hypervigilance, our physical reactions, self-esteem, and avoidance. I invite people when they're also looking at the scales of stress and trauma, always to also include questions around, what are some of the resources, what are the ways that their community and society, culture have survived, have faced, have resisted oppression, and that we're bringing in that into our conversations as well. But again, when we screen, we want to make sure that we're screening and then like, what do we do? What are our clinical interventions and considerations? How do we begin or join someone inside of their process of healing the impact of racism, healing the impact of living in a world, living in a society that is impacted by white supremacy? And bringing, I hope that we are all familiar with, but this is just a reminder of the work by Melanie Trevelyan and Dr. Jan Murray Garcia that was actually began here at UCSF Bineal Children's Hospital, Oakland, around cultural humility. That it's all of our work to be in a lifelong process of critical self-reflection, that this is work that is, never one and done, that we're continuing our own learning, our own assessment, and that we are doing that with each other, that we're asking our colleagues to call us in when we have blind spots, and that we meet that call in graciously and as undefensively as possible and with curiosity, and that we actively engage in our own learning about the cultures of the peoples that we are and the communities that we are serving. Um, that we recognize and do our work to mitigate the inherent power dynamics in our patient-provider relationship. Some of that may include sharing about ourselves and our own challenges. Some of that with boundaries, of course, but naming that, you're a provider or people too, listening again, and knowing that we are always listening for the expertise and joining the expertise of our patients, that we have some expertise that we're bringing to them, but they are the experts of themselves and their experience, and that we are providing options for treatment. Informed consent is a part of this, that we are always providing options, but also listening for and having the patient lead and guide their choices. That we seek to honor the expertise that resides in the communities that we serve, and that we continue to advocate inside of our institution for institutional accountability. Dr. Chavez Dunez has a process of healing ethno-racic trauma called HEARTS, which includes creating sanctuary and safe spaces. Right before I was here, some of our work is around creating safe spaces for LGBTQ youth of color. And so I was there and now I'm here, but really creating safe and sanctuary spaces for community, creating spaces of affirmation and affinity, acknowledging and creating space to reprocess people's experience, building up coping individual and collective care and strategies, because we do live in this world and that we need to be able to function and want people to be able to identify kind of where they are, build up their own resources and coping strategies. So we can do that in every interaction and ask and teach and practice with our clients coping strategies and skills and follow up with them on the next visit. That we're always strengthening connection to family and communities, and there are many different ways that we can do this, including, asking what do patients want to share, who do they want a part of their visits, who would they like to share this information with, who's going to support them, in following through with the treatment plan, connecting to survival strategies and cultural traditions that heal. And again, that goes to what I was sharing earlier around, when we're screening for trauma and stress, we're also screening and deep inquiry about, you have survived, your ancestors have survived, your grandparents and grandparents' grandparents have survived. In order for you to be here, what are those practices? What are those traditions that healed? What are the things that they have engaged in? And that we also know that those communities have engaged in liberation and resistance practices, and that we are in inquiry, deep inquiry around that for ourselves and for our patients and communities that we work with. There also is some work around integration into the positive benefits of integrating racial socializations and trauma-focused cognitive behavioral therapy. And I invite you to start paying attention to what are some of the themes, right? It may be like, oh, I may be able to do this or that, but what are the themes inside of this talk? Again, sharing cultural attitudes, values to prepare a young person to cope with stressors and oppression associated with racial minority practices and status. Ta-Nehisi Coates has the book Between the World and Me, which is a letter to his son around how do we know that racism exists, and so how do I prepare you? What are the things for you to expect? How do you survive inside of this? And really acknowledging that. Um, that to promote cultural pride by teaching and sharing cultural heritage to combat negative messaging. And even inside of our clinics that we're celebrating cultural traditions and celebrations, and that we're joining our community around that. That we're promoting children's awareness of discrimination and preparing them to cope with discrimination, and also supporting families, caregivers, and parents to deal with the heartbreak and the grief of their children's awareness and experiences of discrimination. And that's something that we can do for the parent and the caregiver as well as for the child. And, invite you to be curious about that with your parents, because we know the healthier a parent is, the healthy or a child is. And so that we're creating some support and care for parents as they are preparing and supporting their children to process. Appreciation and involvement of extended family and chosen family, and providing cognitive behavioral strategies to process interpersonal and racial trauma. Some clinical interventions that we've tried in our clinics is, again, considering culture in our assessment and in our written documentation, and also in our diagnosis. And so of being really mindful of diagnosis that may be overly prescribed to certain people of certain racial backgrounds, and really considering in our consultation with other providers and thinking through diagnosis, thinking through the context, inside of our clinical thinking and diagnosis, right? And some of that happens through consultation, being aware and bringing in current events. And again, it's not our own experience, but being aware that this has happened and has an impact. And so is this having an impact on you? What's your effect, right? Again, opening that door, because oftentimes people may not know, is it safe to talk about this? Does my doctor, does my nurse, does my health educator aware that this may have an impact on me, or even care? And so when we bring up those things, then it just creates an opening for the conversation. Integrating, again, cultural-based and evidence-based treatment as the best treatment for our communities. Asking our clients about their experience, and integrating, if we're working with children and adolescents, particularly with adolescents, youth-adult partnership and collaboration. And again, addressing in other ways of utilizing consultation, intentionally holding a frame of race, culture, class. I know I am this race, culture, class. This is my patient. Can I think through this lens? Because I know it's in the room, but if we don't talk about it, if you've ever traveled to another country, you see how much culture impacts who we are, our decision, and our values and what we do, right? And so all of that is in the clinical room. And so we need to talk about it and think about it, because when we don't, we default to dominant culture, we default to white supremacy. And so we need to talk about it and name it inside of our clinical work. And so I'm going to share a few more strategies that providers can use to address race-based stress and trauma, including creating space for grieving and mourning, and acknowledging and humanizing kind of the loss, as we were talking about parents earlier, including the loss that your child may not be growing up in a place that is affirming all of their identities and celebrating them, maybe in a clinic or maybe in school spaces that are not affirming and celebrating them as early as preschool and kindergarten, right? So creating space for grieving and mourning. Again, you'll hear this repeated, acknowledging that racism is a stressor and trauma. And there's so many efforts right now to eradicate and erase that acknowledgement and to erase our history. So coming back to Sankofa, right? We do our best as we're moving forward when we're acknowledging our history and our past, to recognize and validate our students' and patients' experiences of discrimination and racism. It's never our place to say, well, did that really happen? Or did they really mean that? Or maybe you're over exaggerating, or I see that you're really upset. Maybe you can just just cope and move on. But that we really validate someone's experience, because validation, naming something and validating the trauma is a part of the healing. And that we're considering cultural expressions, and how they may of trauma inside of our system of care, right? And how it may look different, for different cultures and communities. Another strategy for addressing race-based trauma and stress is amplifying social supports and connection to community and culture. These are not just words on paper. So it does mean, asking our patients about their community supports, but also having our clinics and our places of healthcare be spaces where we're celebrating and creating community, and also among providers that we're creating a place of connection and support, to culture and to community, and that we're intentionally promoting relation and connection, connectedness. And again, I am aware of that people have so little time. There's so little time, and maybe we can think about this in the Q&A, to do the work that we're doing, but that we are starting with pausing, taking a breath, making eye contact. How are you? Kind of is how we begin any encounter. How are you doing? How's your family? Right? Just that takes less than a minute, can promote some relational connectedness. Thinking about and asking about someone's community and who are the people who are caring for them and holding them up. And we also need to integrate resistance strategies, be a place as providers, for advocacy and social action. And when we see how, many of our residents with white coats for Black lives, and many different ways that people are joining and a part of communities that support their advocacy and work towards social action and liberation. And so as healthcare providers who hold a fair amount of privilege in this world, no matter what our cultural background is, that we are utilizing our privilege, as and engaging in social action in the ways that we can, and that we're also engaging in, and when I speak to also that we're engaging in rest and care, for ourselves as well, and finding that balance. Some great resources for young people and that you can have in your clinics if you're allowed to have books, or that you can share with parents or caregivers or other providers, are the Racial Healing Handbook for Teens and Healing Racial Stress Workbook for Black teens. I know clinicians who have, taken some activities from these workbooks and shared them in their sessions with clients. And again, we're building on hearing the theme of building upon cultural and spiritual strengths, allowing for strategies that support relaxation, which supports, a person to respond rather than react to incidents of racism or trauma or stress, allows for in connecting to that wise self, or that wise selves, right? As we think about spirituality and ancestry, and then responding to what has happened. It encourages community engagement and activities and ways of celebrating joy and cultural pride. I live here in Oakland, Ohlone land, and I know that this weekend is the Black Joy Parade, which is something that our city has done. I think it's their second or third annual year of promoting and celebrating Black joy. Another resource for you is Never Bother, and this was this is a a resource, a web-based resource around depression and suicide ideation, and one that was created by the state of California. And part of their creating this included focus groups and working with youth of color to identify the images, the wording, the content, so that young people can have this to access it for themselves. Providers can also access this. So I want to share this out with all of you. And then some strategies for caregivers, which is, again, supporting caregivers to build a support system and a network. And sometimes if they may not have their own support system, sometimes you're a provider. Let's be real. Like sometimes as a provider, you are that support system and, for parents and caregivers. But there are also hotlines for parents. There are also ways we can direct and nurture and support parents to begin to build their own support system. That we're sharing and supporting caregivers to integrate and share cultural foods and comforts. One of the things that oppression does and racism is create fear, isolation, and divide, right? And so this kind of creates the need to hide or not celebrate how we may be different from dominant society. And so whenever we're celebrating cultural comforts and foods, you notice like my earrings that a colleague brought when they went to visit the African continent, right? Like this is a way of celebrating the culture in which I am rooted in. And so making sure that we're helping caregivers do that for their children and creating letting them know that will improve their health outcomes, right, if they're able to be connected to their cultural traditions and roots. Acknowledging again the harm of racism and that it does have emotional, physical, and relational impact. Many parents, caregivers, generations, part of maybe their survival has been avoidance. And so supporting, moving towards acknowledging that and helping parents and caregivers be able to do that. And in some way, and also sitting with the pain, right? Again, we're talking about trauma. So part of our partnership and helping parents and caregivers to acknowledge is to help them acknowledge the pain that they may be sitting with and how hard it is to acknowledge. Helping parents have open and honest conversations about racism, oppression, and discrimination. And there are many resources now that kind of help parents begin those conversations. I've already talked about being proactive and celebrating cultural diversity. And again, practicing and preparing your child to speak out and to report acts of microaggression and racism that they may experience in our healthcare systems, that they may experience in their schools, and in society. And so this is from the Child Mind Institute, and they have some other resources for caregivers. And for you, the provider, again, you also increasing support, especially now, accessing consultation, and finding the people that you can, trusted people, safe communities to consult and think together, thinking about your documentation and how your documentation, who is going to read it, how to have your documentation really hold up the dignity of your patients and of their lives. Resourcing is here as a way of, and again, whether it's a walk in nature, whether it is engaging in a meal with others, healing justice and reading about healing justice and ways that we're decolonizing our medical and mental health practices. These are some suggestions for you as a provider. And I just want to end with holding that ACEs, again, are not destiny, and that healing is happening. Healing is possible. And the more we create stories and find research and integrate that research into our practices, the more that we can support the communities in which we partnership for their health and well-being and ourselves to keep healing, and to have protective buffers and protective factors from the oppression, and that we're continuing to work towards change, right? As Arundhati Roy says, another world is possible. I can hear her breathing on a quiet day. That we are together working towards creating a world that supports, affirms, celebrates, and is healing for all children and people inside of the world that we live in. And so here are some references and resources. You'll have these in your slides. we are not alone inside of this work. There are many others that have come before us, and there are many others that are coming as well. And I'll stop share. Appreciate your time and attention today and see if we have some time for discussion and for questions.
Thank you so much, Ms. Trotter, for reviewing this topic. Very important for us. I especially really appreciate a few kind of tips that you shared, examining where we're coming from, how we're feeling about the environment in the moment, our own emotions, our sense of safety, and also for our patients, naming it and validating that trauma was real is part of the healing process. Um, I will love to invite all the participants to send your questions to Q&A or to chat, and then we'll have Ms. Trotter review the questions or answer it in live. Personally, I do have some questions I can get us started with. I wonder, you were starting kind of discussing about this already, and would love to hear more about because I found it really helpful for providers, like what to do for self-care and then what to do for the vicarious trauma, or even the firsthand trauma that's being triggered from caring for our patients. And you have mentioned a few really key kind of components, including pausing, taking a breath, making eye contact, checking in with ourselves, with the person we're meeting with. How are ourselves and how are you? How are your family?
Mm.
Anything else or anything that have been helpful in your practice that you've seen?
Yeah, I appreciate that question. I think it's a question. It is as a provider, and it is a lifelong inquiry that I am in and that we are in, and it is so important, that we get to keep choosing into the work that we love, and that is in alignment with our purpose and with our care and with our heart. And so some of the practices that I engage in and that I want to also invite us all into, part of it is like looking for those micro moments of care and resource. And it may be, because I think, yes, we want to make sure, big things we can do. Make sure you use your vacation. Take your time off. Um, you know, be able to identify kind of what are your big rocks and create some boundaries around your time. What's most important? Because there are tiny, tiny micro things that we're always needing to do. So those are some like big things. But I think there are also small things that we can do every day. They're, engaging in a practice, whether a morning or evening practice that is, really helps set a container around your day and that you're starting your day with what is most important and something that resources you. And this may be just some, where you're directing your attention. It could be meditation, it could be yoga, it could be a prayer. It could be, I'm going to like have my cup of coffee and feel the sun on my face and wake up 15 minutes early so I can do that in quiet, right? Things that are going to resource you, but you're beginning your day with yourself. As much as you can. I know that people have children and many demands, but like even 5 minutes makes a big difference, or that you're ending your day with something for yourself. And then throughout your day, sometimes it's making sure that you go for a walk, or that you stand up and stretch, or that you find a window wherever you are and that you look up at the sky. There are times I remind myself, just go outside, step outside the clinic, look up at the sky. And so those are some like smaller ways. I think also consultation and community. None of us, I would not be here without my colleagues and the community that I have built and developed along the time in this work. And so, again, find whether you're listening to, whether you're from grad school to, to the end, to retirement, um, find those colleagues. Those are the ways, those people that you can trust for consultation and support is, definitely, I think, using relationship, such an important way for self-care. So thank you for the question.
Yeah, thank you. So self-care, self-compassion, finding our own community will be really helpful. And I saw that there are some really interesting questions. I'm going to get started with the first one from Lauren Durand. Are there
Mhm.
downsides to diagnosing, so putting a label, a diagnostic label such as PTSD if someone meets criteria related to racism, based trauma, and bullying?
Yeah, that's such a good question, Lori. And I don't think that I think what's important is that we are explaining the diagnosis to our patient and the how we got there and why. I don't think that there is a downside. I think we're contextualizing the diagnosis, right? And that we're identifying the stress that that person has experienced as a trauma and identifying their symptoms. And right now, I want to hold right now, racism-based trauma is not in the DSM-5, right? And so if you are diagnosing, it is a diagnosis, not one that might be available to you inside of your system that you can use, right? And so given that limitation, I think what we have as mental health clinicians right now is um, PTSD. And we're just speaking to, like, here are the events um, that have led to the symptomology, all right, the hypervigilance, the avoidance, the nightmares, the re-triggering intrusive thoughts are because of incidents of racism or kind of the insidiousness of racism. So thank you for that question. I think a bigger, like had more time, a bigger scope is like just the downsides of diagnosing in general, like inside of our field, and right, and that's again how our field, mental health, has been medicalized and colonized, but that's a bigger for another time. But inside of our systems, in order to create access, I think using the diagnosis, but really explaining it, again, informed consent and explaining to your patient or client how you got there.
Thank you. The other question is, can you give an example how one might script a conversation to approach these important topics with our patients? And
Mhm.
considering their age, they're also younger to older patients, so it could be children or teenagers. Are there resources or any language that's readily for use?
Mm-hmm. I mean, we can learn so much from, just such a huge body of work that has been done around ACEs. And so part of it is acknowledging, right? Like, I'm going to acknowledge that the experiences of racism are stressful, like can be stressful, and for some even traumatic, right? I think we want to acknowledge and say that, we live in a world where people experience stress and trauma. These are questions that I ask everyone, right? So again, that we're not pointing someone out, because these are experiences that people have. And I won't know unless I ask, right? And again, I want you to be able to answer me honestly. If there's anything that you don't want to ask or answer, you can let me know that you don't want to answer, and that's okay. So we're beginning the conversation with informed consent. We're being transparent about why we're asking the questions. We're letting them know we ask these questions to most of our patients because it does impact their health. And then beginning the conversation, right? I don't know if, Vivian, if you are medical provider or mental health provider, but I think those, regardless, right, that those are some of the things that we want to start with. We know that this impacts our health, informed consent. These are questions I ask everyone, and this is why. We did do, when we were integrating the ACEs study inside of our clinics, we actually fielded some of those questions with young people with our youth advisory board. And one of the things they said was most important is like, why do you want the information? Why are you asking these questions? And what are you going to do with it? Right? And so if you're asking those questions, part of it is if, as a provider, I want to know this is why, and this is what I'm going to do with the information, it might inform your treatment or what I might prescribe or how we're working together.
Thank you. And personally, I also have found the culturally informed interview very helpful, just coming from a really curious standpoint, trying to offer the young person an opportunity to kind of describe who they are, where they're coming from, because even if they have a similar racial or cultural background, each person has a very different story. So that has been helpful for myself. Next question again from Lori. Very interesting question also. Do you have suggestions for patients who may be disconnected from their cultural identity or practices, and how to help them identify cultural leaders and finding that pride in their community?
Thank you, Lori. Um, I want to just start in thinking about this question for us to hold together why someone may be connected from their cultural identity or practices. Um, and in many cases, and not in all, right? We can't make it all, but many cases, it was maybe because it was not safe to do so, right? And so we have to acknowledge that that may be a symptom of oppression and racism, either for themselves or maybe for their ancestors or elders, right? And so we're always we want to be side by side with our patients. We don't want to be, a step ahead. And I think we lead with curiosity, um, and that, and then we listen. And what does it mean for them? And what is their cultural identity or practices? And what things do they lean upon? Who are, and we listen for where there's opening, and that we have ways that we're celebrating multiple cultures inside of our healthcare centers or inside of our work. But that may be a place of kind of listening deeply and inviting, and continuing to allow the patient to lead, but really acknowledging how many people have lost their languages, many people have lost their access to their culture, right, because of oppression as well.
Thank you. Um, and also, Dr. John shared a resource, a comment rather than a question, that Ms. Trotter has shared the video, A Gardener's Tale, and it has helped the kiddo to understand structural racism. And there's a link in chat for the video. So please use the link if you didn't get the QR code to claim today's CME credit. Thank you all again for joining us today. And we also currently have the Safe and Healthy School Spaces Collaborative on every second Mondays of the month from 9 o'clock to 10 o'clock from March to May. Please come out to cal-map.org for further information, just because there has been a lot of concerns in the community for safety. So we want to offer tips and tools for safety for our kiddos and their families. So we have this new educational offerings for people to discuss and brainstorm. And we have our next webinar coming up. Thank you all for being here today. And again, on March 6th, we will have our webinar focusing on disruptive behavior disorders. Looking forward to seeing you all there. Thank you again, Ms. Trotter, and thank you all for the people who have participated today. Hope you have a great week.
Thank you all. Thank you so much.